Good evening. First of all, I would like to thank Professor Philippatos and Karamasis for the kind invitation. So following this very educational case, let's see a few things about how to treat stent failure, and which has main manifestation is in-stent restenosis, actually, defined as more than 50% reduction of the lumen area, either within the stent or within 5 millimeters proximal or distant to the stent. It's quite often 10%, and we should identify the nature of the in-stent restenosis, hyperplasia, neoatherosclerosis, and the most important is to investigate the underlying mechanism of the stent failure. And as you can see, the predisposing factors are either anatomical factors, clinical factors, or stent-related factors, as we saw in this case. The other manifestation is stent thrombosis, seen in acute coronary syndromes, and we can see stent expansion, malapose stents, plaque at the stent ends, dissection flaps, and lipid-rich plaques. So as we have seen all these cases, imaging comes first. This is the most important, and this is also is coming from guidelines. It's as a recommendation 2A that we should use imaging either OCT or IVUS, and each of these modalities has its pros and cons depending on the case we have on the table. So we have many data from clinical trials regarding intravascular imaging and the favorable outcomes. However, there is no randomized trial about intravascular imaging, particularly for in-stent restenosis. And we talk about it a lot and we take it for granted. However, only 20% of the in-stent restenosis cases is investigated with imaging. And let's see a few things about the mechanisms of stent failure. Stent underexpansion is actually the most common. The stenosis caused is attributed not only to the smaller lumen area, but also to the fact that the suboptimal expansion of the stents creates some unfavorable hemodynamic environment with high wall shear stress, and this provokes neointima proliferation and neoatherosclerotic formation. Coronary stent fracture, another common cause, it can still occur in about 1 to 8% of the cases. Only the most severe fractures are associated with evident intracoronary pathologic changes, and usually up to 50% we report these fractures in the right coronary artery. Predisposing factors is the anatomic location, the stent angulation, and the significant motion of the artery during the cardiac circle. What can we do for stent fractures? If it's a mild stent fracture without any significant in-stent restenosis, some propose that it is reasonable to continue even a longer duration of dual antiplatelet therapy. If the stent fracture is more severe and there is flow-limiting stenosis, then the use of additional stents usually is used. Longitudinal stent deformation is another mechanical cause. Nowadays we have thinner struts with fewer strut connectors and more flexible stents. This is okay, this is good for deliverability. However, this seems to be associated with decreased longitudinal strength of the stents. And what can we do? We can treat it either with post-dilatation and implantation of an overlapping stent to cover this area of deformation. Stent recoil. The thinner strut platforms that we have today, there were some concerns regarding the possible reduction of the radial strength of these stents. However, based on IVUS studies, there does not seem to be a significant loss in radial strength and the risk with the current stents. What can we do? Aggressive post-dilatation and only if needed, placement of a second stent within the lumen. Tissue prolapse, finally. It's quite common. Depending on the imaging modality, you investigate the prolapse. You see, there is more than 90% of tissue prolapse if you use OCT. However, the first generation stainless stents demonstrated less tissue prolapse compared with the newer generation stents. However, there seems to be no correlation with MACE and tissue prolapse. But in case of acute coronary syndrome of a STEMI with high thrombus burden, there is increased risk for tissue prolapse and maybe distal embolization. So there are a lot of algorithms about in-stent restenosis. I found a lot of common paths in these algorithms, and all of them agree to just one thing, that imaging should come first, and this is the first thing we have to do in order to investigate the etiology, and based on that, we go with a treatment. So if there is a mechanical in-stent stenosis, including fracture under expansion, then we can use high-pressure balloons, rotablation, IVL if there is a lot of calcium. On the other hand, if there is a biological type of in-stent stenosis, then we talk about hyperplasia and neoatherosclerosis. If there is one layer of stent and it's focal, then again we can use high-pressure balloons, cutting balloons, and then if needed, depending on DES or a drug-coated balloon. If there are two layers of stent, okay, again we can use high-pressure balloons. However, we should avoid a third layer of stent, and then we should think about a bypass surgery if needed. So despite the significant improvements of the coronary stent designs, there are still several mechanisms of coronary stent failure, and we should be able to recognize these mechanisms. And intracoronary imaging is the most important tool we have to recognize the underlying mechanism, and based on that, we should plan the treatment options that we have. Thank you.
So, Kostas, thank you very much. I think you actually pointed out the malapposition, the underexpansion, all the other things. So we're going to proceed.